we're going to go ahead and get started tonight. This is Northern Virginia Family Practices Town Hall series, the Be Well Virginia series. We're so happy that everybody is here with us this evening. We have a great speaker, someone that I actually know pretty well. This is Dr. Alex Krist. He's a professor of family medicine and population health at Virginia Commonwealth University, and also a practicing family physician at the Inova Fairfax Family Practice Residency. And this is actually where I met Dr. Krist back about 20 years ago when I was just getting out of medical school and starting my training at Fairfax Family Practice. And I always remember Alex as being just a fantastic teacher and always somebody who was teaching me to go towards the evidence. So this is something that has stuck, and it's a little bit what we'll be talking about this evening. Dr. Krist directs the Virginia Ambulatory Care Outcomes Research Network, a collection of over 500 primary care practices that partner to conduct research that matters for primary care. Dr. Krist is a former member and chair of the United States Preventive Services Task Force, and he served between 2014 and I guess just recently, just this past March of 2021. So he is personally interested in putting evidence-based recommendations into practice, the art of shared decision-making, and also the use of health information technology. So without further ado, I'd like to welcome Alex Krist to the program. He'll be giving a presentation, and I think, Dr. Krist, we had talked that if people have questions in the middle of the program, we want this to be as interactive as possible. You can go ahead and type your message in the chat or raise your hand, and we'll see what we can answer for you. So,
yeah, 100%. So I think thanks for the introduction, Cecily, and I appreciate that. As she was saying, I've been at the residency office now since '99 is when I started as faculty.
Okay, so that was close.
It was pretty close, yes. And I figured out the math. I've actually had a chance now to help train 190 residents and family physicians over the years. So it adds up over time, which is kind of scary. So I was going to talk for you all about the U.S. Preventive Services Task Force, and it would be a little bit more fun if it was interactive. I was going to try and talk about concepts and sort of how decisions are made nationally about preventive care and what people are thinking about. So it's a little bit of healthcare intertwined with understanding evidence, and then how guidelines are made. As Cecily was saying, I'm going to try to watch the comments. If people type things into the comments, then we can divert at any point and kind of talk about what it is people want to talk about. But maybe I should start with asking a question of, has anyone heard about the U.S. Preventive Services Task Force? Has anyone heard of that organization before? And you can type into the, so Ken and Cecily, you could type.
The doctors have.
So, okay, well, good. That'll be kind of all right, a good basis for how we talk. So, and I'm gonna use this to kind of tailor some of what I'm gonna say in response to that. All right, great. So the one thing I'm trying to do, give me one sec. I'm gonna pull up the chat so that I can see if folks are saying something. And I'm going to try to put that in a place where it's, because I guess you see the chat if I put it up there. Okay, good. So, and I'm going to try to frame this a little bit about kind of being a good healthcare consumer. As Cecily mentioned, part of my job, I see patients, I teach, and then I also do research. I spend about half my time doing research, and she'd mentioned about working with 500 practices throughout the state. So we actually, pre-COVID, would drive all over the state to these different practices to try and help practices. And most of it is about how do we help primary care practices do a better job about implementing the type of care that we know. So it's how do we put these systems in place so that we're offering the best preventive and chronic care and other things that we need to folks. So what I was hoping to share a little bit was how people, how clinicians and policymakers are thinking about making decisions like what preventive care should we do or not. So I'm going to talk a little bit about what is this U.S. Preventive Services Task Force that you hear about, that I mentioned, what's its approach. I'm going to talk a little bit about outcomes and how prevention can actually hurt you, a little bit about shared decision making, how we think about what we know and what we don't know. I'll talk a little bit about insurance coverage, which is an interesting issue, some conflicts of interest, and then some topics that have been emerging more recently about structural racism and how this affects health for people. So it's a very broad range that we'll cover here. But when you think about prevention, we often talk about three elements of prevention. So one of the first is what we call primary prevention. And so this primary prevention is doing things to prevent something before it ever occurs. So this is like eating right, exercising, not smoking, so that you don't get heart disease, you're less likely to get cancers and other types of issues. Secondary prevention is when we try to look to find a condition early, when we can do something about it before it's kind of spread and then we can't deal with it as well. That's what secondary prevention is. And then tertiary prevention is when someone has a condition after you've developed heart disease or you've had cancer. It might be trying to prevent it from progressing or preventing it from occurring. And we often think of a couple buckets of preventive services. So there's screening services. So this is like when doctors ask patients to get their cholesterol checked or get a colonoscopy. There's counseling where clinicians might be talking with patients and saying, hey, let's talk about what you're doing right now with eating right or exercising and see about helping you with that. There are preventive medicines. So this might be like aspirin or vitamins. And then we think of immunizations. And, fascinatingly, we were talking there a little bit about the beginning with vaccines. If you think about preventive medicines, probably the COVID vaccine is the most effective preventive service that we've ever developed in our lifetimes. It actually went from killing 1 in 700 Americans last year to, in the trials, no one dying who got the vaccine, which is pretty much unheard of across preventive services, which is really interesting. So I asked at the beginning, so if you'd heard of the U.S. Preventive Services Task Force, and I'm going to talk about its general methods. It's a group, let me actually start with this slide here. So the U.S. Preventive Services Task Force is this independent volunteer body. It's not part of the government, and they've been around since the Reagan administration. And they started by just trying to evaluate the science and the evidence to make sure that clinicians and patients knew what did we know and what did we not know, and what did the evidence show about preventive care, and then how do we use that to decide what we should or shouldn't be doing. And it's existed ever since the Reagan administration, and they've used to come out with books that would go through all the preventive services and say what to do or not to do and the evidence behind it. And then now it's all, of course, web-based, and they publish articles every month or two to try and help clinicians with this. And then more recently, we'll talk about this, they've come much more into the limelight because they've been linked to the Affordable Care Act into coverage. And so it's sort of been considered in many ways the gold standard of prevention recommendations. Now, when I say it's considered the gold standard, recognize for a second that I'm biased. So I was a member of the task force for 7 years. I just finished serving as the chair of the task force, so I am clearly biased in this. But the task force has these two missions. So overall, what they're setting out to do is to try and improve the health of all Americans by making evidence-based recommendations about preventive care. And then really the second thing, and the point that I actually like to say most, is that what the task force is trying to do is to try and make sure that clinicians and patients understand what the science says about preventive services. And you'd think this is easy, but it's actually extremely complex. And I'm going to try to show you some of that. So the task force is making recommendations about primary and secondary prevention. So they're not making recommendations on how do you treat conditions. It's how do you prevent them from developing or find them early when we can do something about it. So it's really for people who have no signs or symptoms, people who are healthy and not experiencing a condition. There are 16 members of the task force. Anyone can actually self-nominate themselves or be nominated, but they all represent the primary care disciplines. So this is family medicine, internal medicine, nursing, OBGYN, pediatrics, behavioral medicine, there's public health, there's nursing. So it's a group of people who are really expert on evaluating the science and on preventive care. And sometimes if you watch the news and people don't like a recommendation from the US Preventive Services Task Force, one of the big criticisms always is there's no experts on the task force. And so I'll show you, we've got recommendations around prostate cancer screening or breast cancer screening. And people will say, well, why is there no oncologists or other folks like that on the task force? So to put into context, this group makes recommendations about 20 a year, and there's 88 different preventive services with about 150 different letter grades. And they span everything, all of health, and really primary care, family medicine, internal medicine, nursing. They're really the experts in prevention, not the cancer doctors who are experts in cancer. Um, all of the members serve just a 4-year term unless you go on to be chair and vice chair, and then you stay on for an extra 3 years. And that's done partly on purpose because you want to have different people over time serving in these roles, so that you get good perspectives across the whole body of evidence. And what happens is there's a whole national process that's in place to go through and figure out what should we be making preventive recommendations on. So any person at any point in time can nominate topics, and government and professional organizations and other societies can nominate topics to be considered. And then the task force goes through and they review all the evidence. And as they do this type of a process, they actually publish a couple different steps of the way on how they're going to look at the evidence, how they're going to make the recommendation, and they try to get public input and input from the different topic experts that I mentioned on. And then they actually come out with a draft recommendation, get public comment, and once again, publish that after getting all of this public comment. So there's this very deliberative process to get all kinds of public input on this and to make sure that it's a very open, transparent process. Now, here are the two things when the task force is looking at the evidence, and I think this is really important to think about prevention and actually making medical decisions in general. So when they look at all of the studies and things like that, they want to look at how sure are we from this data? How certain can we be to be able to say what the harms and the benefits are? And then the second thing that we want to do is to say, when we look at all of this data, what is the net magnitude of the benefits? So if you add up all the benefits and you subtract out the harms, are we going to help more people than we hurt? And at the bottom, what I have there is actually the most important thing, which is when the task force looks at the evidence and says, look, we can't really tell from this. There's not enough certainty. The science isn't strong enough. They actually come out with what's called an I statement that says there's insufficient evidence. We can't say what people should or shouldn't do. And sometimes people get very frustrated with that. But the whole grounding of this is that the different recommendations on what we should be doing for prevention are not about expert opinion and what people think we should be doing, but it's really what does just the evidence and the science say. And the task force comes out with these letter grades, these A, B, C, and D. And what the letters mean for the task force members, an A or a B means that we've got moderate certainty, what you see on that left side of the graph, that there's at least a moderate net benefit of the preventive service. And a C, which we'll talk about in a second, means there's moderate certainty that there's a small net benefit. And then a D means we're pretty certain that there's no benefit or it might hurt people. Now, what it means for practice and what clinicians hear is these A and B grade when we look at the evidence. This means that that's something that you would routinely offer to people as part of care. A C might mean you selectively offer it. So it has a small net benefit. It might help some people, but it might not. And a D would mean that you don't routinely do it. And then that I, going back to that where I said at the beginning, that means that there's insufficient evidence. And that really just means we don't know and we need to find more evidence. And we'll talk about that in a second. So on a very basic level, when making a prevention recommendation, I think one of the things that we think is most important is a lot of times we look at these different conditions and we think, well, there's a lot of people dying from this or from that, or this is really hurting people, so we need to do something about it. And that's always a good starting point. So we want to take these different conditions and figure out how we can help people's health and well-being. But when you're thinking about prevention and particularly screening, we want to ask a couple of questions. Like, first of all, can we find it early? So there's a lot of medical conditions that even with the tests that we have today, it just starts so quickly, it spreads so quickly, you can't find it early. So you take something like pancreatic cancer. It's a big deal. It's the sixth leading cause of cancer death in America. And if we could do something about it, we'd want to do something about it. But the problem is it goes from not being detectable to being untreatable in just this narrow window of weeks. So then the other thing becomes, does finding it early make a difference? So another example would be something like ovarian cancer. And we know that ovarian cancer kills a good number of women, and that's something that we want to deal with as well. But our treatments generally aren't that great. So we have treatments that might try and help to slow progression, but in the long term, they don't make a big difference. So finding it early doesn't make a difference. And that leads to, do we have a treatment for it? So there's other things we can find that we just don't know what to do anything about. And then does treatment help? And then do the harms outweigh the benefits? So we'll talk about some of those things, but that's the basic framework when thinking about any of these different preventive services. One of the key things that we think about is what are the outcomes? Like, what do we care about when we're looking at the science and whether something does or doesn't help someone? So I think one of the most important things that we're looking at is what we call a health outcome. And from the task force's standpoint, what we're thinking about is this is anything that you experience. So the way we phrase this is we want to be able to show that a preventive service either improves your length of life or your quality of life. That's really important. There's another set of outcomes, and you're probably all very familiar with these. The task force calls these intermediate outcomes. So this might be things that could influence your health, but they're actually not something that you necessarily feel. So this is like your blood pressure or your cholesterol or something along those levels. So they may lead to health impacts, but just changing your blood pressure number in of itself, unless that goes on to prevent heart attacks and strokes, which we have evidence that it does, doesn't necessarily make you feel better. So we're very careful when we're looking at the data to say, look, we want to make sure that we can show that this improves the length or the quality of life. And so that's what we're looking at as a lens. So I want to give you an example. You probably hear a lot about vitamin D. And people talk a lot about vitamin D. It's all over the news. And a little bit later, I'll show you why it's all over the news. And actually, low vitamin D levels are super common. So these are three different thresholds of low vitamin D. One is a level of 12, 6% of the population has that. Another is a level of 20, 24% of the population has that. And another level is 30, and 64% of people are below 30. And the labs all mark a low vitamin D level as below 30. Well, 2/3 of the population has a low vitamin D level in that case, which is kind of crazy when you think about. And then you'll hear in the news all the time about low vitamin D levels are associated with all these bad things. You know, it can cause fractures, falls, it can make you weaker, not think as clear. It can increase your risk of cancer, diabetes, heart disease, depression. You're more likely to get COVID and to die from COVID, and you're more likely to die overall. So this sounds like a terrible thing, and it sounds like something that you want to deal with and to treat, the vitamin D level. But when you go and you look at the data, there's been 25 different trials on nearly 100,000 people treating people with low vitamin D. And for the most part, it doesn't change any of those outcomes, which is a very strange thing to think about. So if it's associated with all these adverse outcomes, we really should be able to show that if that's what's causing it, when we treat it, it should make these go away. But the data doesn't show that. Now, I'll tell you right now, the task force kind of gives screening and checking for vitamin D one of those I statements. So we say, even the fact that there's 25 studies where it doesn't show an improvement, we've looked at that and said, well, you know, it has such strong associations, so we need more evidence and more science. But there isn't anything to suggest that this may necessarily help. And a good classic example of a similar story at the bottom I have is hormone replacement therapy. So we used to think this helped women immensely. You know, it lowers your cholesterol and has all these physiologic effects. It's much like the hormone levels of a younger woman. And so, of course, replacing this will improve outcomes. And back in the 1990s, someone decided they wanted to study whether taking hormone replacement therapy to prevent disease and keep you healthy would improve an outcome. And they turned a big grant in, and NIH said that's unethical to do because it's been proven it's beneficial. Eventually, they actually got it funded, and they found that hormone replacement therapy to prevent disease actually did the exact opposite. It didn't prevent any disease. It actually causes heart disease. It causes cancers. It causes strokes. It causes depression. And so just doing it for preventing disease is incorrect. Now, I see Jim asked a question about who tells the labs what low is and how is it determined? And that's an awesome question. So most of the lab values that you get are the normal range is what is defined as 95% of the population has, okay? So if you are in that 5%, that means you're 2 standard deviations outside of the normal range. And that's how the labs often define this. And to your point, Jim, which maybe you weren't getting at, but I think is really important, is really we want to think about something as being abnormal as if it's in that value, it causes problems for you. And if we treat it, it makes a difference. And so this abnormal for vitamin D, what the right level is very highly debatable. And, you know, when the task force looked at screening and we looked at those studies, we were looking more at the 30, the value of 30. A lot of those studies included patients who had the higher levels threshold for abnormal. If you're down at 12, you're probably slipping from prevention more into a disease management type of a state. But this gets to be very complicated in saying what's normal and what's not. If you look at your lab sheets about what's normal for your LDL cholesterol, the labs have defined that as 100, and 100 was what one guideline body at one point in time said should be the value if you've had a heart attack or stroke. But they also went on to say that if you have just 2 or more risk factors, the value should be 130. And if you have no risk factors, it should be 160. So those little lab values of what's normal or not normal on your LabCorp or Quest lab ranges, you have to look at those with caution and talk with your doctor about what does it really mean? And is this an issue for you? And does it matter? And please keep typing in questions here. I think this is very helpful. So I put here some examples of some preventive services that we looked at that I've already mentioned, things like looking for ovarian cancer and pancreatic cancer. And the task force gave those D recommendations. And a large part of that is because while they're harmful, well, we don't have treatments for it. Another example of thinking if you have treatment, you might have heard about things like non-traditional cardiovascular risk factors. So I'm using medical jargon now, and I apologize for that. But a non-traditional cardiovascular risk factor is something like measuring your C-reactive protein or one of those coronary artery calcium scores. And so when you look at the data on that, what we can actually find is that, okay, yes, having a high coronary artery calcium is associated with a greater risk of heart disease. But there's actually no study that shows that doing anything different as a result of that changes outcomes. So some people argue, well, you know, if you have coronary calcium, we should treat your blood pressure, your cholesterol. But if you go back and look at the prevention guidelines, well, we should be doing that already. So that really shouldn't change what we're doing. And just as it can tell you that you're at increased, there can actually be false increases as well as negative increases where it doesn't tell someone there's an increased risk and they really are. And then at the very bottom, there's another example of a preventive service, which I just want you to think about, which is testicular cancer screening. And the task force gave that a D recommendation also. But the reason it's a D recommendation is because, quite interestingly, our treatments for testicular cancer are phenomenally good. So something like 99.9% of people who get testicular cancer do not die from it. Our treatments are great. And so if you go back and you think about screening and preventing illnesses, if you've got a treatment that works 100% of the time, you can actually just wait until people have symptoms and you can treat them then, and you don't need to be thinking about screening and prevention. I want to talk for a second about harms. And this is an interesting topic, and it's something that that people get confused about and people have strong opinions about. So we often think about the benefits of screening and prevention. Clearly, doing a lot of things do help our health, and we want to do that. But it's also important to think that some of our preventive services do have harms as well. So anytime we do a test, it has a risk of a false positive. The other thing that there's risks of are what we call overdiagnosis. So sometimes we find things that are never going to affect you in your life, and we'd never know about it. And we only know about it because we tested you for it. That's overdiagnosis. And then that leads to overtreatment. And so the consequences of some of the false positives, overdiagnosis, and overtreatment are things like invasive procedures or anxiety or sometimes unnecessary treatment. And then on a public health level, sometimes if we start recommending things before we have the science to support it, we actually ruin our chances to find out if it really works or not. I put here a book by Shannon Brownlee called Overtreated. It's actually a really amazing book. And I'm not meaning it to promote anything, but it really kind of goes through the different issues about where doing too much can actually hurt us more than help us. So I want to show a couple examples. This is prostate cancer screening, and prostate cancer is an important topic. About 1 out of 10 men will get prostate cancer in their life, and about 2% of men will die from prostate cancer. So this is a big deal, and it's something that we'd like to do something about and to be able to treat better. What this shows is kind of a pictogram of what happens to 1,000 men who get screened. And at the bottom, there are benefits. So what you see is if 1,000 men get screened, we'll prevent 1 man from dying from prostate cancer, and we'll prevent 3 men from having metastatic disease. And that's a good thing. If that were it, we would just say everyone should get screened for prostate cancer. Now, what you also see is that 5 men still die from prostate cancer. So screening it doesn't prevent all deaths. In fact, it prevents 1 out of 6 deaths. At the same time, above is what you see are some of the harms. So about 240 men who get a PSA test will have a high PSA. And for many of them, we can't tell if it's cancer or not. So they might go on and get a biopsy, and that can cause pain and bleeding and infection. And then about 100 men will get diagnosed with prostate cancer. And some of those are overdiagnosed. And that's about 20 to 50 of those 100 men, where what it means is we wouldn't know they had it unless we checked them for it. We can't always tell which ones are overdiagnosed, which ones are going to progress and be the one that will kill a man. So many of those men go on and they get treatment like surgery or radiation. Now we have treatments like active surveillance where we can watch people with this now. But what happens is out of those 100 men, about 80 we see go on and need to have surgery or radiation. And then that leads to erectile dysfunction in 50 men and urinary continence in 15 men. So you can see there's this benefit of preventing death, but then there are these harms of false positives, overdiagnosis, overtreatment. And from the task force standpoint, we came out with what's called a C recommendation. So we're saying that it has a small net benefit. And in practice, for clinicians, those C recommendations often mean to kind of think about the benefits and the harms and think about what's right for you. So like one man might hear all this data and say, I'm really worried about prostate cancer, and the reductions in death are worth it to me. And other men might hear this and say, that's a lot of false positives, and I'd be really worried about that, and I don't want to go down that path. But this gives you an idea about where there are potential harms.
Hey, Alex, can I ask a quick question?
Please.
At some point, we used to do the digital rectal exams, and that is, I've noticed that sort of just fallen off recommendations altogether. Can you speak to that a little bit?
Yeah, so the digital rectal exams actually have very little, actually have no value in terms of screening. So, and you can imagine, we thought they did, and when you and I were
I know most men aren't too upset to see this go away.
No, not unhappy to see this go away. So, and I'll admit, as a doctor, I'm not unhappy to see it go away. It wasn't the most fun procedure to do. But I'm sorry.
From either side. Yeah.
Exactly. Yes. So if you imagine this, your prostate's a solid organ. Cancer can occur anywhere in it. And when we do the rectal exam, all we can do is feel a little bit of the prostate. So you can feel if there's this nodule or something else like that, but that's about it. And so you actually miss most of the things. And the PSA is much more sensitive than that. So like by the time you could feel anything, you'd have a change in your PSA. So what's quite interesting is in all the big trials to study prostate cancer screening, which were started in the 90s, like the big US trial called the PLCO trial, they started with rectal exams, but they actually dropped it out from the protocol within 1 year of starting the trial because it was so, it actually causes a lot more false positives. It just increases your false positive rate without doing anything to reduce your death rate. So it was dropped out of all the trials. Now, screening is different from following up someone who has a high PSA. So if a man gets a PSA and it's high, it might be appropriate to check it. And it's also different from if someone has symptoms and you're checking to kind of evaluate symptoms. There might be reasons to do it then. So unfortunately, it doesn't mean that we never do a rectal exam, but we just don't need to do it as much as we used to.
Yeah, I usually tell patients I don't do it for screening anymore. However, if there's symptoms of an enlarged prostate, it's good to get a sense of, what might be going on there and get a sense of how big it is.
Exactly.
So, and then we've also have a question from Ray and Linda. Does the rate of change in PSA make a difference?
Yeah, it does. And so, when you're thinking about prevention and how to make preventive care better too, right, on a population level, you can make it better by reducing the harms. So one of the harms there would be to figure out who really needs a biopsy and who do you really need to check. And so that's where we look at things like the rate of change. We look at the absolute value. We look at the rate of change. You look at the percent free of the PSA, and those are all things that you can look at. Quite interestingly, here in the US, we've often said that a value of 4 is abnormal, right? So in the big trials where screening made a difference, they actually had 7 different countries in Europe that did it. And 2 of the countries defined an abnormal PSA as above 3. And in those countries, any man who had a PSA over 3 in the trials went on and had to get a biopsy, which is a lot of men, actually. It was a lot of men. They had another country, Finland, and they defined abnormal as 10, which is crazy. In the US, we start getting anxious above 4. But that rate of change is something that we often will look at and try and use that to try and better differentiate who needs and who doesn't need biopsies. So there's a lot of these things, and that can be, if we get better ways of treating prostate cancer, that can also reduce those complications of erectile dysfunction or urinary continence. And that changes that balance of benefits and harms too. But I think one of the messages the task force has had about prostate cancer screening is PSA is not the best test. And actually, we really need something better to find and prevent prostate cancer. We need better treatments. And people are looking a lot at this. They're looking at MRI, which could be good, but they have to get the cost down on that for sure. And that has its own set of harms. So I was going to show this other slide about harms. And this is an interesting one to think about. So when we looked at the evidence for screening for colon cancer, one of the tests that you can do is a virtual colonoscopy. So I don't recommend virtual colonoscopies for my patients, and it's partly because of this. Although I will tell you that the task force said that we found evidence that virtual colonoscopies will prevent death from colon cancer. So the task force does recommend it broadly. But one of the things that we found are what are called extracolonic findings. And Cecily, I saw in your email out to the group talking about full body CT scans. This is probably your best evidence on understanding that. So in these trials, there were 9 different trials, about 30,000 people in it, and they basically compared how good is a virtual colonoscopy to a regular colonoscopy. That's what the studies did. But what they found is these different type of finding outside of the colon, and they're characterized as E3, which means they're likely unimportant, or potentially it's incompletely characterized. Now, a certain number of those E3 findings needed further testing. And then there's E4 findings, which are, oh, these seem important, we're worried about these. And it's a little scary looking at some of these trials because these E3 findings occurred in somewhere between 3% of people and 30% of people who had a test. So And then the E4, these are the potentially important findings, were in between 1 and 12% of people. So this idea of, like, you start doing CAT scans on people and looking at their body, you actually find lots of things. And most of them probably aren't significant, but these E4 are radiographically defined as important findings. And actually for these trials, just under 3% of people had to go on and get definitive medical or surgical treatment, not for their colon, but for things outside of it. So they would find a tumor on the kidney or something in the bladder or something else. And so that 3%, these are people getting things like chemotherapy, getting a cancer removed, getting an invasive biopsy. Um, and the disturbing finding in these trials is that despite finding these things and doing something about it, for 3% of people, which is a lot of people, it didn't change any outcomes. And that's sometimes because finding these things early don't make a difference. Maybe it wouldn't progress. It would be that overdiagnosed thing, or maybe the treatment didn't make a difference in these cases. And it's a little hard to think about that, but it is kind of disturbing to see that there's so many findings that are abnormal, and yet they don't go on and make a difference if we treat them. Now, I want to be clear, I'm not downplaying and saying prevention is bad, okay? I know I'm talking about some of these negatives, but it's because it's thinking about being a consumer around these things and thinking about, well, what are the things that are going to have more benefits than harms, and what are the things that we have good certainty on and that we know improve a health outcome that'll help you to live longer or to feel better. And this is a concept here for implementing a lot of this. This is what we call shared decision making for these C recommendations. There's only about 9 services that kind of fall into this middle category. But shared decision making, and this is a great concept for anyone thinking about being a good consumer of health, but this is sort of thinking about it in the context of prevention. It's when you think about a preventive service, you want to understand, well, what is the risk or seriousness of the disease I'm trying to prevent? You want to think about, do you understand the preventive service, including the benefits, harms, and uncertainties? Like, do you know what it means to have a colonoscopy? Have you had a chance to weigh your values regarding this decision? So like I just said, with prostate cancer, that's one where we do more shared decision making because there's this balance of benefits and harms. So the right decision is the one that aligns with your values. That's how we want to do that. And then we want people to be engaged in the decision-making level that they want to be engaged at. So sometimes I'll go through and explain to my patients pluses and minuses of a test, and they'll say, doc, just tell me what to do. And then I'll ask them a couple questions to understand their values, but um, telling them what to do after I've done that is actually still a shared decision. And Martha, you asked about cost. Actually, I'm going to use that as an opportunity to jump ahead, and I'll jump ahead and then I'll jump back. And let me talk about insurance coverage for a second, because the task force, when they're looking at the evidence and they're making A and B and C and D recommendations, all that we're looking at is the evidence and the benefits and the harms. We actually don't look at cost. So that's very important to know. And we do that on purpose because we don't want people to be saying that the task force is saying you should or shouldn't do something because it costs a lot or doesn't cost a lot. The whole job of the task force is to say, what does the science show, and does this help more people than it hurts? Now, as a society, we do have to think about cost, no question about that. But the task force is saying we don't want to mix up the science and our understanding of the science with our understanding of the cost, and that's someone else. So the Affordable Care Act has these provisions in it where it says that any A or B task force recommendation has to be covered by commercial insurances without cost sharing. And that means there should be no copay. You should be able to get the preventive service for zero cost. The other things linked to coverage in the Affordable Care Act are any immunizations that the Advisory Committee on Immunization Practices recommends. And then for kids, there's a different set of guidelines called Bright Futures, and that's by the American Pediatric Association. So all of those have to be covered by commercial insurances at no cost to patients. There's also a clause in here, though, saying that you have to cover these things is not saying that you can't cover the other things. So this is up to insurers' discretion about saying, okay, this preventive service, prostate cancer screening, it's a C recommendation. We don't have to cover it, but a C means we've got moderate uncertainty of a small benefit, so we are going to cover it. And most all insurances and Medicare do cover prostate cancer screening and a lot of these other services that aren't just A and B services. But the interesting thing about this is prior to the Affordable Care Act and this linkage to coverage, it literally used to take an act of Congress for Medicare to cover preventive services, because Medicare was only authorized to pay for acute and chronic care. So when breast cancer screening was first covered back in the 90s, Congress had to meet and vote on whether Medicare would pay for breast cancer screening, which is just a terrible way of trying to have efficient coverage from a Medicare perspective. So the Affordable Care Act really helped Medicare to cover more preventive services and brought preventive services front and center into coverage. So I'm not sure if that gets at your question, Martha. There are other groups that look at cost and that try to say, okay, this is too expensive or not too expensive, and we will cover this or won't cover it. But if it is an A or a B recommendation from the task force, they have to cover it by the legal mandate of the Affordable Care Act. Everything else, they may look at things like cost effectiveness and the value to decide if they want to cover it or not cover it. I was going to talk here a little bit about that insufficient evidence, and certainly as a patient and as a doctor, you know, hearing that we have insufficient evidence to recommend for or against something is pretty frustrating. And you hear this and you think, well, that doesn't help anyone. Someone should say what to do. The task force is one of these groups that just looks at the evidence. There are lots of other guideline groups. So you'll hear about the American Cancer Society. You'll hear about the American Diabetes Association. Different professional societies will make guideline recommendations, and a lot of them will do it based on professional opinion. And so as doctors, we'll often go and look across a whole bunch of guidelines. And so when I see an I recommendation from the task force, I'll look at other guidelines and other evidence to try and help inform my decisions with patients. But the I statement from the task force actually becomes very important. And this is just a little politics. I know it's not healthcare, but I think understanding sort of how our medical engine works is interesting. The task force once a year turns a report into Congress. So we go through and we outline all of the gaps in the evidence, all these I statements and other things. It gets turned in as a report to Congress. And then Congress takes this report and they give it to the National Institute of Health. And the National Institute of Health is charged with closing those evidence gaps. So every year they have to report to Congress on how many studies they're funding that address these different evidence gaps. And one of our success stories here is lung cancer screening. So up until 2014, lung cancer screening was an I recommendation. And if you didn't know it, lung cancer kills more people than breast, colon, and prostate cancer combined. So, I mean, this is a big deal here. So all of those reports to Congress and NIH getting this launched this large study called the NLST study, where they funded a big randomized control trial to see if you randomized people who smoke a certain amount to get screened for lung cancer, will we save lives? And the answer was yes. And not only did it save lives, it saves more lives than colon, breast, prostate cancer screening all combined. So in the trials, this big trial that they did on smokers who were being screened, 1 out of 3 people in the trial died of lung cancer in the 7-year period of the study. So in the big European trial for prostate cancer, which included 158,000 people, only 2,000 people died from prostate cancer during the whole trial. So you could see that lung cancer is a big deal. And what we recommend is anyone who smokes, if you have a 20-pack year history of smoking and you're between the ages of 50 and 80, you should get a CAT scan to try and find lung cancer early. And this does save lives. So that's kind of one of these successes of that insufficient evidence and going from that to studies to closing evidence gaps.
Question, Alex, about that. So is that an annual screening that you would do, or until they kind of phase out of that 15-year since they've quit, or how do you factor that in?
The answer to that is yes to both of those questions. So it's once if you continue to smoke and you have a 20-pack year history of smoking between the ages of 50 and 80, you would get a CT scan every year. Now, ideally, you'll quit smoking. And one of the other recommended preventive services is for doctors to counsel you to quit smoking and for you to quit smoking. And 19 out of 20 lung cancers are caused by smoking. So you want to prevent lung cancer, quitting smoking is the best thing you can do. So if you're 15 years out from quitting smoking and you haven't gotten lung cancer, the good news is your chances of getting lung cancer start to dramatically drop off. So if you are 15 years out from smoking, then you would stop getting screened and check for lung cancer. So
if I can ask a question about that as well, I've seen that certainly the evidence showed that it certainly does decrease, prevent deaths from lung cancer. But my understanding is doing the CTs, that smokers are also people who get benign lesions, and that there was a huge rate of biopsies and inappropriate surgeries that ended up with significant morbidity for lesions that were not cancerous. And so, you said you weigh it with the risk of death versus the risk of harms. And I know there was a lot of harms with this as well, though. So how did you factor that in, and where and how did you go to a B versus a C based on that?
Yeah. So the benefits in terms of deaths prevented were just so high that's where it got to the B. But you're exactly correct. So 1 out of 4 smokers who get screened will have an abnormal CT scan. That's not surprising to imagine. If you've been smoking for 20-pack years, there's scarring and changes in the lungs, and we see that. Now, one of the good news, going back to what I was saying before about if you can improve and focus in on who should or shouldn't be have follow-up testing, there's a whole set of radiographic classifications of those lung cancer findings, and those have been really developed a lot better over the past 5 years. And if the radiologists implement that and use that classification, you actually, in terms of biopsies and surgeries, you reduce the number of biopsies and surgeries by 80%. You still have a rate of that. So while the task force does give it a B recommendation, there's actually language in there still to say, well, you should do shared decision making. And one element of the shared decision making is how are you going to feel if you have an abnormal lung scan? Is this going to make you really anxious and worried? And if you had cancer, would you want to have surgery? Because the treatment is removing part of your lung. And so if a patient says, well, I don't think I'd want to have surgery, that would be a good time to kind of stop lung cancer screening. And that actual kind of sentiment applies to a lot of the preventive services that we think about. So if you take, for example, colon cancer screening, the advantage of screening for colon cancer is you can find colon cancer early when we can do something about it. And the treatment for colon cancer is removing the colon cancer. It's surgery, it's getting a partial colectomy, and you end up with an ostomy for some time period, and later they can hopefully reconnect things. But when a person gets to a point where they say, I think if you found colon cancer for me, I don't think I'd want to have that surgery, that's a good time to kind of stop colon cancer screening, and something to think about there with that. And so that's how some of those decisions on when to stop these preventive services come about. Another way is like with prostate cancer screening. So for prostate cancer screening, there actually comes a point in men's lives where they're much more likely to have prostate cancer than not. So something like 40 to 50% of 80-year-old men have prostate cancer on autopsy. They didn't die from it, they died with it. And some of those cancers that would occur in an 80-year-old man are not the type that would ever progress and go on and affect a man in his life. In fact, they would never leave the prostate. And it's not just because it's related to the nature of that type of cancer at that time. It's different than the cancer that a 50-year-old man gets, which tends to be much more aggressive. So
I think, yeah. Oh, I'm sorry, Alex, go ahead.
I was just gonna say those are just the things that are thought about and sort of how you think about when you stop doing things as well.
Yeah, and speaking of just stopping, I don't know if you're going to talk about that, but that's always kind of sometimes a difficult conversation when you're doing your your visits with your patients, and they reach a 65-year-old woman who is trying to understand, well, why don't I need a pap smear anymore? Or at 75 we start talking about, I think you alluded to the fact we stopped doing colonoscopies, but I think, could you speak a little bit more to that, to the why we stop? It's not that we don't care, sometimes it's like, it's not that
Absolutely
we're
not.
giving up or anything. It's just the
No.
evidence doesn't show this is going to help anymore.
Right. And, it's different for some of the different things. So as I was saying with like prostate cancer, one of the reasons for stopping it is the type of cancers that an 80-year-old man gets are the type that would just stay in the prostate, never spread, never affect them. The type for breast cancer, um, uh, uh, breast cancer, your rates go up as you age. And so that's true. Breast and colon cancer rates go up as you age. It really gets to be a point more about like the risks of the treatment and would people tolerate and want the treatments. And if you get to a point where it's like, okay, doing that colectomy, that's not something I'd want to do, or the mastectomy, which, it's not as invasive as a colectomy, but it's still invasive. Or the risks of surgery start going up, you balance those types of things. Cervical cancer is an interesting one, which you mentioned. What's different with that is all cases of cervical cancer are usually due to a human papillomavirus infection, which is sexually transmitted. And you get it not just from getting human papillomavirus, but you get it from getting human papillomavirus that won't go away for 30 years. That's what causes it. So it's the teen, the 20-year-old who gets HPV, and it stays there for 30 years. That increases their risk of cervical cancer. So above the age of 65, if you've never had human papillomavirus, you're less likely to get it. And if you do get it, it's got to be there 30, 40 years to cause cervical cancer. So, so that's some of it around that. So. I wanted to close on two different things, and I know we're, and please, I'd like people to ask other questions if they want, but I want to show a little bit about something to be cautious about with prevention. Prevention is something that applies to everyone. So that means you have a very wide market. So you can deliver preventive services to every American. So there's a lot of money and a lot of big business behind it. So this was a very interesting article in the New York Times, and it was looking at vitamin D and vitamin D supplementation and the industry behind it, and specifically certain individuals. And this is a $10 billion industry selling vitamin D. So it's just important as you think about that to kind of say, well, what are the types of conflicts of interest that people have when they're recommending this or that, and to think about that. This is some slides about a company called Exact Sciences, and they make Cologuard. So that's that colon cancer screening test you see on TV every day, right? On the right-hand slide, you'll see some stock market ticker levels. And back in 2016 was the first time the U.S. Preventive Services Task Force looked at Cologuard as a potential preventive service. And we issued a draft recommendation where we recommended Cologuard, but we actually recommended it as a secondary or alternative test because we thought it wasn't as good as the other ones. What happened is their stock in one day went from $20 a share to $9 a share. And what also happened is this company only makes one product, and they were going to move into Madison, Wisconsin, and revitalize the inner city. And so all of the task force members the very next day got letters from the senators of Wisconsin saying we should recommend Cologuard because it's a good preventive service. So now the task force did, and we did before, but we'd said it was an alternative test. We actually ended up taking that language out, but that was because many of our primary care groups said that was confusing language, but we did mean it wasn't necessarily as good of a test as the colonoscopy or even the stool blood tests. But you can see there's a lot of money in this. And then here are different guidelines. This is some breast cancer guidelines made by the American Radiographic Society. And Jim, I'll go back to those C services in a second. But every single author in this got money from industry. And they're the group making guideline recommendations. So the U.S. Preventive Services Task Force, we're not allowed to have any conflicts of interest or they kick us off. But as an example, too, to put some of these dollars into perspective, there's this organization called Open Payments. It's by CMS. And you can go into here, type in any doctor's name, and you'll see how much money they get from drug companies. So this doctor, Michael Hollick, is the doctor recommending vitamin D. He got $61,000 from the drug companies that make vitamin D. But when we were making one of our recommendations, we were looking at someone who was giving us a lot of feedback on the C-reactive protein test. And when we looked him up in Open Payments, he got paid $50 million by drug companies. So this is not small amounts of money that you're talking about driving prevention and behind it. And so you have to be a little bit careful with that. I'm going to talk about the C recommendations for Jim, and then I'm going to close a little bit on health equity and race and racism. The C ones, these are interesting because what it means is from the task force perspective is that we're saying it has a small net benefit. And it doesn't mean you shouldn't be doing them. And they're also associated with existing recommendations. So we say screening for abdominal aortic aneurysm. So we know men 65 to 75 who have ever smoked, they should be screened. That's a B. But if you've never smoked, it's a C. The benefits go down because they're at lower risk. And so this would be more of a discussion with the doctor as to whether it's right for you. For aspirin for men and women 60 to 69, that's a C. But for men and women 50 to 59 who are at, and what's not written here is that you have to also have a 10% heart disease risk. Men 50 to 59 and women, it would be a B. Now I'll put a placeholder here. The evidence on aspirin has changed and it probably doesn't work for primary prevention. And I'm not disclosing anything, but just I wouldn't be surprised if the guideline changes. So for primary prevention, but if you've had a heart disease or a stroke, you'd want to take aspirin. Breast cancer screening for women 40 to 49 is a C. Women 50 to 74, it's a B, routinely do it. 40 to 49, it's a C because the way the math works is if 1,000 women don't get checked for breast cancer, 25 will die. And if you do a mammogram every 2 years, starting at 50, instead of 25 women dying, it'll be 18. So you save 7 lives, and that's important. If you start at 40 instead of 50, instead 17 women die. So you save 1 extra life per 1,000 screened, which if that were it, the task force would give it a B, but it's also a trade-off of that false positives over diagnosis and over treatment. So to save that 1 extra life, about 150 women will have a false positive on a mammogram, and about 50 women will need to get a biopsy. So some women hear that and say, well, I'm worried, I want to start at 40. And other women hear that and say, well, that doesn't sound like as good of a test. I want to wait till I'm 50. And that's where it's a C. The colorectal is a C for 75 to 85. So that gets into deciding, well, what's the right age for you to stop? And the way I put this into practice with my patients is I say, well, if you had colon cancer, would you want the colectomy? And the ones who say no, that's the time to stop. And prostate cancer is the C, as we talked about. The statin for preventing heart disease, this is for lower risk people. If you have a 10% cardiovascular risk, it'd be worth taking a statin, but if you're lower risk, it might not be. And the healthy diet and exercise being a C, this is for people who don't have any cardiovascular disease and who aren't overweight. It's actually a B. And the recommendation, it's not about eating healthy and exercising, it's about whether doctors should spend the time to counsel patients to eat right and exercise. And some of that is, it's hard to change these things. And, a doctor saying you should eat right and exercise, that's not going to fix things. It's actually really hard, and we need more intensive interventions to help people to do better with eating right and exercising. And fall prevention, it's actually recommended that we do counseling for preventing falls for people who've had falls or at risk of falling. And the intervention that's recommended, that's a B, is physical therapy and strength exercises. And it's actually a C for what's called these multifactorial interventions, where you go and do all these evaluations into factors leading to falls. And that's because that doesn't help everyone. And what would help everyone who's at risk for a fall is the physical therapy and the strengthening exercises and those things.
Alex, can you go back to that slide real quick and just ask you one quick question? Because a lot of them, several of them, it says, to prevent colon cancer or cardiovascular disease. Originally you had said that all the recommendations are based on health outcomes, not secondary outcomes. So why is aspirin prevention or the health and diet and statins say for prevention of cardiovascular disease rather than prevention for improvement of longevity and quality of life?
Yeah, well, I think that's more semantics, actually. You're exactly correct. So like with aspirin to prevent cardiovascular disease and colon cancer, we saw the data that preventing these events of heart attacks and strokes and preventing colon cancers did help people to live longer, and it did improve the quality of life. But we are trying to differentiate that it was taking aspirin for those reasons, because those were the outcomes that led to the improvements as opposed to other things. And with the statins, the big benefit was that we made a switch. It used to be about screening for high cholesterol. That was the guideline. And then we really kind of shift the paradigm. It's not about just what your cholesterol level is. It's what is your risk of heart disease. And if you have a high enough risk of heart disease, then taking this medicine prevents heart disease, which improves your length and quality of life. And so while it is a little bit semantics, it's because we're changing how we thought about the purpose of cholesterol lowering medicines. I think very much of cholesterol lowering medicines and blood pressure medicines as reducing a risk factor that will prevent events, that will help you to live longer and have a better quality of life. That's really what we think about. So,
Alex, there's a great question from Linda. She asked, so does not wanting a colectomy justify not having a colonoscopy at all, ever? If you were at 50, never wanted a and some of this, I think, is to be said with colonoscopies. We can also find polyps in early cases of. So anyway, but I'd like to. What is your opinion on that?
I actually think the answer to that is yes.
Mm-hmm.
And what I mean by that is the benefit of the preventive services following through and getting the treatment for the conditions that you find early for screening. So if you never would do the follow-up, then I do think it's reasonable to decide not to get colon cancer screening. Now, I need to temper that, because the thing I tell my patients is that, look, 2% of people die of colon cancer. The average person who dies of colon cancer lives 13 years less than someone who doesn't. So getting screened for colon cancer, there's a 2% chance you're going to live an extra 13 years. I mean, that's a pretty big benefit. Now, that being said, every one of us as people have agency over our own bodies. So if you don't want to be screened and you don't want to do this, you have that right. And I do have a couple of my patients who throughout their whole lives have refused to get screened for colon cancer. I have a couple, and now they're in their 70s. They've not gotten colon cancer, but I've seen them for 25 years. And every year I say to them, I'm going to ask you this. And they're like, yeah, I know, I still don't want to do it. That's their choice. But Linda, I do try to really emphasize 2% chance of living an extra 13 years. That's a big deal. So do we need to stop, or do you want me to say something about equity and other things?
I think we can keep going. If people need to leave, they can, but I'm interested in hearing about it. So if you can stay, we'd love for you to talk about it.
So let me just say, we hear a lot about equity and how this contributes to health. We hear a lot about systemic racism and things like that, and how that contributes to health. And we have really good evidence that inequities lead to poor health outcomes. And so actually the task force has started taking a mind towards thinking about, well, how do we address this? And in many ways, if we think of as a nation, if we improve health equity, that actually probably do more to improve the health of our population than a new, better preventive service. Just making sure that people got what we know works. And I want to show you a little data, and some of this is a little, I find it disturbing. So like in the US, if you look at life expectancies, for example, for Black people, it's 12 years less than Asian people. There's a spectrum of age differences, but certain races and ethnicities consistently have worse outcomes. This is the 10-year risk calculator for men and women for their heart disease risk. And what's in red here that you can see is if you look at all races, if you look at a 40-year-old who has a 10%, look at 40-year-olds, 5% of 40-year-olds have a 10% or more risk of heart disease in the next 10 years. 15% of Black men in that column have a risk of heart disease. And then if you look at 50-year-olds, it goes from 30% of the general population to 60% for Black men. And we see a similar trend with women. And if we look across preventive services, we see consistently worse outcomes with certain groups. So most often, so it's Black people. So an example being breast cancer, Black women are twice as likely to die from breast cancer. For colon cancer, Black men and women are twice as likely to die from it. For prostate cancer, Black men have a 4% chance of dying from prostate cancer. Now, one exception is hepatitis C. And right now, white people are more likely to have hepatitis C. And that's all driven by the opioid epidemic, most of which is occurring in rural white populations, although that's actually now changing over the past couple of years. So the task force has kind of adopted an approach to systematically think about race, inequities, and how racism impacts health. And we started with a premise of saying that we were going to think of race as a social factor and not a biologic factor. So the fact that Black men are twice as likely to die from prostate cancer it's not due to biology. It's actually much more related to social issues and social factors. And this gets into how your environment affects your health and other things. And we started to go through and try to systematically look at the evidence for this. And our most recent colon cancer recommendation, which we just updated 3 weeks ago, actually, lowered the age to 50. But one of the tasks that we did was we tried to look for evidence to say, should we make a different recommendation for Black adults than other races and ethnicities because they're more likely to die from colon cancer? And when we looked across all of the evidence, we found consistent differences in access to screening, the quality of screening, the time from diagnosis to treatment, and the quality of treatment that Black people got compared to other races and ethnicities. And we did some modeling work, and we adjusted for these differences. All of the differences in mortality from colon cancer went away. So we actually think that this is pretty good evidence right here of systemic racism, just to be blunt about that. So this is part of how the task force is trying to look at that. And actually going back to our calls for action, when we make evidence calls for insufficient evidence, we actually took this data and said, look, we need to think about how do we improve our systems of care? How do we make sure that the healthcare systems taking care of Black communities are giving good access to screening, good quality of screening, are getting people who are diagnosed with cancer to treatment quickly, and getting the best quality of treatment so that we can improve these outcomes. And I'm hoping that 10 years from now, just like with lung cancer screening, we might see evidence that we can make a difference and that there can be interventions that can reduce some of these inequities. And this leads to some basic things I wanted to point out to everyone too. If you think about what contributes to health, the determinants of health, this pie chart on the left side is something that we see all the time. So socioeconomic factors are about 40% of how long you live and your quality of life. Your health behaviors are about 30%, and the environment you live in is 10%. And all of our healthcare industry is about 20% of your health and well-being. And when we think about like socioeconomic factors, there's all this data that like being under stress and having difficulties goes and changes the genetics in your body. It changes how your body responds to things. And it even changes the genetics that you pass on to your children. And then those health behaviors, if you look at 3 health behaviors, tobacco use, poor diet, and sedentary lifestyle, they cause 50% of all of premature deaths. So a premature death means you died younger than you should have. But those 3 behaviors, not smoking, eating healthy, exercising, can reduce your chance of dying at a younger age by 50%. Now, the 4th one that's on there is unhealthy alcohol use. But I think those are pretty profound when you start thinking about these various determinants of health. And then you start thinking about that in the context of structural racism and equity that we have in our society. So this is some of the things that the task force is trying to look at as we're making these recommendations, in addition to what's going to help everyone to improve their health. I think that's much of what I had. So I did go over, and we're trying to do questions as we went, but I can stay on for a moment if there's other questions too.
That was fantastic. A lot to think about. So and if I don't know if anybody has any other questions, you feel free to use the chat, or you can even raise your hand, I think, or I'm not sure if we can unmute. That would require me to know how to use the system here.
If I could just make a comment, if you don't mind, for those of you out there, nobody really had ever heard of the U.S. Preventive Task Force. And for those of us in the know, this is like the all-star team. I mean, this is, and he's the captain of the all-star team. If the people in medicine, especially in primary care, this is the top of the top. And, there's very few things that I do without the okay of the USPSTF. I use them as my #1 resource for trying to guide most of what I do every day. So for me, this is, I've got stars in my eyes watching this. It's really, really impressive. And thank you so much for being there to give anybody else an idea of how big and how important this sort of unknown, obscure group of people are. They really have a huge impact on how we practice.
Absolutely. We're kind of, in primary care, we're kind of nerds for the United States Services Preventative Task Force. They're just, this is good stuff. This is how we practice medicine. So.
And I would also suggest to you, as in my own personal bias, as anybody who's seen me will understand, that I would add that 5th behavior beyond alcohol would also be sleep as a determinant of outcomes, as a huge, huge impact on outcomes. That is also has a very big race connection as well.
Yeah. Okay. All right. Well. Full body screening. I think you alluded to that a little bit, Alex, just in terms of the more harm than good that comes out of that.
Yeah, I try to discourage my patients from getting it. And like, as I said, with the colon studies, we found lots of ancillary, other findings that we don't know whether they really made a difference or not. And doing something to someone, if it doesn't make a difference, could be a harm. And then same thing with like the coronary calcium. There's no data really that finding that changes an outcome. So, the way I'd really be thinking about it is, if there's a concrete thing to do, and we know that it improves the health and well-being, that'd be a good thing to do. But you hear ads for full body CTs on TV and on the radio, and I think it's like the Drew Clinic or something in this area advertises. And, if you call and you check, you got to pay for it yourself. And the reason you have to pay for it is because there hasn't been good evidence that it's improving outcomes. And I have had a few of my patients get it, and I can't think of anyone it's helped. And actually I've ended up, chasing our tail, kind of working up a lot of stuff and worrying about a lot of stuff. And that makes me nervous for my patients. Going back to the money bit, the full body CT, it's a money maker for radiologists. They make a lot of money on it. So going back and thinking as a consumer about, is this something that's being offered in my best interest? In fairness to radiologists, I think they do believe that finding disease is stamping it out. And that's not a bad thing, but I think we need a little bit more data that on someone who's consuming that information and trying to help my patients act on the information, there's not a lot to act on with that. So.
Yeah, and there's the mental health also and the quality of life that impacts as well. So that's also something to be, the chronic worry and like you said, the chasing, the quality of life plummets a lot of the time. And that's something I think we have to pay attention to as well.
And going with quality of life at the moment, I didn't mention about mental health a lot, but right now there are recommendations to screen for mental health. And they just estimated that 40% of Americans now are depressed or have anxiety after COVID and everything. And to your point, Cecily, it's exactly what you said. I'll see people really worrying about these findings. It can be scary seeing that you have something and what do I do about it? And then, we'll follow it and worry for a long time about it. And if that helps improve an outcome, it might be worth it. But if it's not, then we've caused anxiety without benefit.
Yeah. And that's actually a fantastic segue since we're out of time, and I need to plug the next town hall meeting that we're having, which is going to be June 17th. And speaking of mental health and the effects that COVID has had on us as a society, we'll be looking at this one more time. I know Robin Rectal, who's a psychotherapist in the area, will be joining us, joining me. And Dr. Beauvais will also be on this town hall. We'll be discussing the new mask mandates or lack thereof, I guess, or the changing patterns of use of masks, what this means physically, but also emotionally, and sort of where we've been for the last year, where we are now, and psychologically, how we can safely move forward and live happy lives now that we have something, the vaccine that we're getting a leg up here with on COVID here. But what this means emotionally, sometimes is different than what it means physically. So, but anyway, I want to thank Dr. Krist once again for coming on. This is a fantastic talk. I feel like we could just go on and on for hours. So maybe we'll have you back on for part 2 so we can talk a little bit more and see if people have more questions. But thanks again to everybody for joining us. Northern Virginia Family Practice Town Hall, Be Well, Virginia. Have a great evening and hope to see you next time. Bye-bye.